area, at the door, then it would be a different conversation. But, I don't think it was unreasonable to try to get some steroids on. And with the amount of latency she got, the baby, would have had some benefit from that. But it's definitely a risk benefit discussion.
I see Dr. Sinofsky has her hand up.
Did anyone look into why this patient never came for prenatal care? I mean, she clearly has a history of multiple problems with prior pregnancies. And were there social determinants of health or other factors that prevented her from coming in to be seen?
Hi, this is Julia Knipinski. Can you guys hear me?
Yes, we hear you.
Hi. I'm biased because I'm the one that admitted her in terms of her management, but in terms of her prenatal care, the patient said that she knew she was very high risk and had several attempts to contact our OBGYN office to get an appointment, and she was unsuccessful.
And that's actually documented in the chart. I was asked to review this, and there's several attempts for her to get in, and it was not on the hospital side; it was in the cab. And just a quick addition is that there was no room for expected management past 48 hours in this patient. Even if this patient has health, but she's otherwise stable, the steroids for 48 hours will reduce major complications, including neonatal death, by 30%, RDS by 50%, intracranial bleeds by 30 to 50%. So that 48 hours of steroid for the baby's sake is crazy important. But to say we're going to go past 48 hours, if that was ever the plan in this patient, was probably not something we should be thinking. I'm not sure if that was presented the way maybe MFM was thinking about it. But to say I want to get 48 hours, Josh, out of this baby is extraordinarily reasonable and maybe best practice.
There was absolutely no plan to go past 48 hours.
Yeah, I just want to be clear. So.
All right. Well, thank you, Devika. Thank you so much for that excellent job.
Thank you.
All right. So we're going to start transitioning now into grand rounds. In just a minute, I'm going to ask Dr. Montero to introduce our grand round speaker. But in the meantime, just a word or two about attendance. So we'll be taking attendance by using the participants list this morning at 8:10. If your name is not displayed clearly, you can email your attendance to me or Beth or Michelle. Please, for this and all future WebExes, consider putting your first and last name, especially unless you have an extremely unique first name. It's always a struggle for the people who are trying to take attendance or figure out who belongs and who doesn't when people only type their first name. So in this professional environment, please type your first and last name. And with that, Dr. Montero, are you ready to introduce our speaker?
I am. Can you hear me?
Yes, we do.
Okay, great. It is my pleasure this morning to introduce Dr. Qiana Brown. Dr. Brown is an epidemiologist, translational scientist, social worker, and assistant professor at Rutgers University School of Social Work. From a health equity lens, her research focuses on system-level change to improve maternal and child health, centering on preventing prenatal substance use and examining the role of built-in and social environments and health and social policies in shaping substance use and other health outcomes among women, youth, and families. Dr. Brown is a member of the board of directors for the College on Problems of Drug Independence. Additionally, she was named one of the Society for the Study of Addictions Women of Future Influences in Addiction Science. Dr. Brown earned her PhD in mental health and drug dependence epidemiology from Johns Hopkins University and completed a postdoctoral research fellowship in substance abuse epidemiology at Columbia University. She has also founded and directed a nonprofit community-based substance use disorder treatment, Jane's House of Inspiration, named in honor of her late mother. Welcome, Dr. Brown.
Thank you. Thank you for the introduction. I'm so excited to be here with you at Grand Rounds. I want to thank the department and the School of Medicine for inviting me. And I'm going to talk with you rather. I'm hoping that this will be an engaging session, talk with you about preventing potential unintended consequences of cannabis use legalization for pregnant people. So I have no financial disclosures to report, and I just want to tell you a little more about myself. I know I just had a wonderful introduction, but I like to start off these types of talks with my why, right? So, like many of you, I am a scientist practitioner. My career to epidemiology, specifically drug dependence epidemiology, was not linear. I was a nurse early in my career, many moons ago now, almost 20 years ago now. I was an Army nurse earlier in my career, and I later became a public health social worker and founded this drug treatment center for women, Jane's House of Inspiration, named in honor of my late mother, pictured here. So beautiful, right? So, Mike, I've dedicated my career to addressing addiction, particularly addiction in maternal and child health, because my mother cycled through periods of relapse and recovery throughout her entire life. And this is a picture of us celebrating a milestone in her recovery. And like any mother, instead of focusing on herself at the party, she brings gifts to the party for me. So I like to show this picture not only because it's my mom and it tells my story, but to remind the audience that there are real people behind the science and statistics of addiction. And it matters what we do and say as scientists and practitioners. It matters to their lives. We directly impact them with our actions and our publications for that matter, and we indirectly impact them. So yes, today I am going to talk to you about the science of addiction. I'm an addiction scientist, but I'm also hoping to motivate you to maybe do and say things a little differently to directly impact the lives of people and families who might be suffering from substance use disorders. Now, we're not going to talk about every substance use disorder today. I'm going to focus on prenatal cannabis use, and because you have to start somewhere, right? So the objectives of this talk are for you, the audience, to recognize trends in prenatal cannabis use, identify at least one potential unintended consequence of cannabis legalization for pregnant individuals, and to express how you can help prevent potential unintended consequences of cannabis use legalization for pregnant individuals, both at the clinical and macro levels. And I want to emphasize the macro level piece because it is hard to even find time to operate outside of the clinic if you're working 80, 90 hours a week. And I've been there or earlier in my career as a nurse, going a whole shift without, even a double shift, without having a restroom break, seeing multiple patients. So I get it. But I'm hoping to share things with you today, not only steps that I've taken to help improve clinical care and macro level practice, but I want you to develop your own steps because it is possible to do. So those are your objectives, and we're going to later in the presentation develop action steps that you can leave with around these objectives. So here are some questions that I want you to think about to help you drive change, right? What is your role in addition to clinical care in preventing and reducing disparities in prenatal cannabis or other substance use? What is your role beyond clinical care or in addition to clinical care in addressing social determinants of health associated with prenatal cannabis or other substance use? And what is your role in promoting health and social equity for people who use cannabis, particularly in the context of cannabis use legalization or other substances during pregnancy, right? Also, is the current system working? Whatever system you're within, whatever you're thinking about as your place, as the organizational structure that affects how you operate, is that system working in this regard? If not, how can you help change it? And what support do you need to drive change? So these are the questions that I want you to think about throughout this presentation. And I ask you to think about your role beyond clinical care, because when we think about factors that impact health, substance use and substance use disorders included, clinical care only accounts for about 10 to 20% of those factors that shape health. The other factors are more upstream social determinants of health. So social determinants of health are accounting for 80 to 90% of the factors that impact the lives, the health and well-being of our patients. So if we want patients to thrive, we have no choice but to address social determinants of health. And it's a tall order to do in the clinic, but we have to find time to do it not only in the clinic, but beyond. And hopefully we can come up with some strategies for that today. So social determinants of health, just as a reminder, are conditions in the environment where people are born, live, learn, work, and play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. And many of you, I'm sure, already know this, but it's not always easy to address these factors in the clinic and certainly outside of the clinic, but we have to, and we have to do this in a way that we can promote equity for health and social equity for patients and their families. So the primary social determinant of health that I'm going to focus on today, as you can gather by the title of my talk, is right here. If you can see my cursor moving, that's cannabis use legalization, cannabis laws. Cannabis is legal. Cannabis use is legal in New Jersey for medical and recreational purposes, but it's also legal in most of America. So we have to think about the impact or potential impact of policy on the lives of our patients and what we do to prevent unintended consequences of those policies. And I'll come back to this model, but I just want to orient you to it here. And we'll go point by point, but the big picture, before we come back to it a little later in the presentation, is I want you to think about, in terms of addressing social determinants of health, how can you intervene at each pathway depicted in this model, right? There could be potentially a direct path, for example, between cannabis use legalization and prenatal cannabis use. The research shows that women who live in states where particularly recreational cannabis is legal, the odds of cannabis use or prenatal cannabis use is higher for those women compared to women who live in states where recreational use is not legal. So what are we going to do about that? Again, in the clinic and outside of the clinic, right? How, and the same thing for each pathway. What are you going to do in terms of addressing the potential impact of cannabis use legalization on perceived risk of cannabis use, on the accessibility and availability of cannabis use, right? But we'll come back to this in a bit. Let's get into the epi before we come back to the model. So let's talk about the epidemiology of prenatal cannabis use. So I've published a paper in JAMA and it's been cited time and time again. And what I wanted to examine was trends in cannabis use amongst all reproductive age women. So reproductive age women in the United States, both pregnant and non-pregnant. I hypothesized that cannabis use would increase over time among reproductive age women over these 13 years from 2002 to 2014. And this is this main line. So when I'm talking about my hypothesis at this point, I'm talking about the line in the middle, the black line, right? So I hypothesized that cannabis use would increase amongst reproductive age women over time. Past month cannabis use, and because that is normally a measure of current cannabis use or current substance use. So if you use substances in the past month, you're considered a current user. So I hypothesized that past month cannabis use would increase over time among reproductive age women in the United States. However, I hypothesized that these trends would be moderated by pregnancy status. such that non-pregnant reproductive age women, panel B here, trends would increase significantly among non-pregnant reproductive age women, but cannabis use, prenatal cannabis use would remain stable over time, right? So why would I hypothesize that? In the literature, cannabis use is increasing in the population in general. Non-pregnant women, non-pregnant reproductive age women don't really have a reason not to use cannabis unless they were planning pregnancy in the pre-contemplation or the preconception period, or they were breastfeeding. But I could not, in this study, determine whether they were breastfeeding, recently pregnant, or planning to have a baby, right? But unless there was some type of contraindication, non-pregnant reproductive age women would not have a reason to not use cannabis recreationally or otherwise. So I figure their trends, or I hypothesize that trends in cannabis use amongst that population would be similar to the general population, where we already knew prior to publishing this paper that cannabis use was increasing and in the population as a whole. Pregnant women, back to panel A, have a strong motivator not to use cannabis. They're pregnant, right? Pregnancy is a strong motivator for people to stop using drugs. Moreover, if they're engaged in prenatal care, you're likely getting health education from your healthcare providers to promote a healthy pregnancy, no drug use, and you would have no reason to say those same things to non-pregnant women, and they're not coming to prenatal care. So this is why I hypothesize that prenatal cannabis use will be flat over time. Again, we're at this black line. I'll talk about stratifying by age soon, right? What I found was that certainly prenatal cannabis use increased over time amongst non-pregnant amongst reproductive age women in general, but it was not just driven by non-pregnant women. Prenatal cannabis use also increased over time. So from 2002 to 2014, there were 50,000 more, give or take, pregnant people who used cannabis in 2014 compared to 2002. This was a 62% increase in prenatal cannabis use. I did not expect to see that. I did not hypothesize that. In terms of non-pregnant reproductive age women, cannabis use increased as well. So about 2 million more non-pregnant reproductive age women used cannabis in the past month in 2014 versus 2002. And that represents about a 47% increase over that time period. And as you can see, when stratified by age, younger women, both those who were pregnant and those who were non-pregnant, had a higher year-to-year point prevalence of cannabis use in each year compared to those who were 26 to 44 years old. So cannabis use was higher amongst 18 to 25-year-olds during pregnancy and amongst 18 to 25-year-olds that they were non-pregnant compared to 26 to 44-year-olds, right? So back to my main hypothesis, this black line here, I hypothesized that pregnancy status would significantly moderate increases in prenatal cannabis use. It did not, and that's counterintuitive. There should be a difference in substance use between pregnant women or pregnant people and non-pregnant reproductive age women, but it was not a difference over time. Trends, cannabis use increased just as fast amongst non-pregnant women as it did for pregnant people. And that's concerning, given that it's recommended that women abstain from cannabis use during pregnancy during pregnancy, pre-conception and postpartum. So what happened after this study, right? I don't think anyone expected to see this. After this study, another team replicated my work. So they wanted, as new data came out, these data are from the National Survey of Drug Use and Health, both the my paper and the team that replicated the study. Cannabis use increased to nearly 5%. Prenatal cannabis use, the prevalence of prenatal cannabis use increased to nearly 5% by 2016, right? We're here, the blue line. That is 110% increase since 2002 in prenatal cannabis use. And although the point prevalence of prenatal cannabis use is lower each year than that of prenatal alcohol, here, black line, and prenatal cigarette use, this is the only substance of the three that's increasing over time. Prenatal cannabis use is increasing over time. Prenatal cigarette use is decreasing over time, right? So we have some wins here in terms of prenatal cigarette use that we are certainly not seeing regarding prenatal cannabis use, right? And we have to ask ourselves why. Is there a substitution effect going on here? We would need more research to examine that, but it's something to think about. If these trends continue to go up in terms of prenatal cannabis use, what are we going to do as researchers and practitioners? I was discouraged to see that the trends in prenatal alcohol use remain flat over time. I mean, it appears to be decreasing a little bit, but this is not a significant decrease. There have been public health campaigns since the 70s in terms of the risk of prenatal alcohol use, such as fetal alcohol spectrum disorder. And we are making no significant gains in this area, right? So something has to happen. People are still trying to understand how harmful prenatal cannabis use is. We certainly know prenatal tobacco use is harmful. And thankfully, trends are decreasing in prenatal cannabis use at the population level. So in the US, prenatal alcohol use, we have much more work to do if we don't want to plateau out here, which we seem to have done. So, and more data came out, right? So this is a topic that a lot of people are interested in. More data came out. Another group of researchers replicated this study in part, and they wanted to use the latest data, which examined trends in prenatal cannabis use until 2019. And what they found was from 2016, that was the last year from the last published study in this area. From 2016 to 2019, the prevalence of prenatal cannabis use stayed about the same. There were no significant differences, no significant changes. So it may be encouraging that it's not increasing, however, it's staying the same. So we want to be able to reverse those trends because, again, the recommendation is that pregnant people abstain from cannabis during pregnancy, right? But in order to reverse the trends or to just understand more about why pregnant people are using cannabis in the first place, we have to think about not only the socio-political context, the socio-political environment that we live in where cannabis use is legal, but we also have to think about their risk perceptions. There's no shortage of studies that examine substance use and substance use disorder that show in the general population that when perceived risk of a drug or substance is high, that the use of that substance is lower. So it was new to examine perceived risk amongst pregnant individuals. So let's think about where we are. Cannabis is legal in most states in this country. So there's a lot of misinformation, and patients have to contend with this. If you're giving them helpful information in the clinic and they're getting misinformation everywhere else, they're with you a small proportion of the time, right? They're getting misinformation potentially from cannabis dispensaries, from the internet, from their social networks around the safety of this now legal drug during pregnancy. And there's research that I've cited here, particularly this Dixon et al. Article that shows that, at least in one study, right, that bud tenders, so when you go to purchase your cannabis from the cannabis dispensary, bud tenders are giving pregnant women, again, in one study, misinformation. They're saying, oh yeah, it is safe during pregnancy. You should use it for morning sickness. They're making specific recommendations. And in this study, obviously, it was a mystery caller, so there was some deception. They did not send actual pregnant people to buy and use cannabis, but the research team called the dispensary and said, I'm pregnant, I'm in my first trimester, having morning sickness, what should I do, or what type of cannabis that should I use? Both medical dispensaries and those that didn't have a medical classification gave supposed pregnant women, they did not know until after the study that the people who were calling them weren't actually pregnant, but gave them recommendations. The last I checked, bud tenders did not go to medical school or any type of school that would allow them to make essentially health and medical recommendations to pregnant people out of all populations, where now the mother and the fetus is potentially at risk. So when you're seeing your clients or seeing your patients in the clinic, these are things that we have to think about for the 5 minutes or so, maybe 15 that you get to see them. What's happening in society? How are they reconciling the misinformation, right? And so that's one thing to consider if we really want to think about preventing prenatal cannabis use and reversing the trends that are currently increasing. So in terms of perceived risk of cannabis use during pregnancy in the US, right? So these are nationally representative studies in terms of perceived risk. Among pregnant people in the US who used cannabis in the past month, there was a 153% increase in them reporting no risk associated with regular cannabis use, right? There's some face validity there. They're already using cannabis. So if you're using it, it's reasonable that you think that it's not so risky, right? What was shocking to me about this study was this 300% or almost 400% increase in reporting no risk associated with regular cannabis use among pregnant people in the US who did not use cannabis in the past month. These are people who aren't current users who are thinking that, well, this drug might be safe and safe during pregnancy. 371% increase over time. That's concerning. So I wonder, how do you, maybe you can tell me, I've not been in the clinic for almost 20 years now. How do you contend with this if your patients don't perceive no risk associated with cannabis use during pregnancy, given the plethora of misinformation I'm sure that's out there, and the population level trends that's saying cannabis is safe, and the fact that it's legal in most states? What are you doing in the clinic? I would gather, and maybe you'll tell me during the question and answer session, that it is an uphill battle for you. But hopefully, like I said, towards the end of this talk, we can develop some action steps that will make it more streamlined. So certainly we have to think about perceived risks or risk perceptions in prenatal cannabis use in terms of preventing it, and how to circumvent or combat the misinformation that our clients might be getting, right? Another point that I wanted to examine, at least in my research, in terms of thinking about how to best prevent and understand really cannabis use and cannabis use disorder amongst pregnant and postpartum women, was to understand mental health correlates of cannabis use. I figured risk perceptions are decreasing, but in the United States, particularly amongst pregnant people, but also amongst non-pregnant reproductive age women. They're perceiving that cannabis use is essentially safe or no risk is associated with it. So maybe they're self-medicating if they have a co-occurring mental health disorder. So in a recent study, I wanted to examine this, and I did. So what I found here in terms of mental health correlates of cannabis use and cannabis use disorder is that amongst this, these are pregnant and postpartum women in the US. I found in terms of past year mood disorders that most mood disorders were associated with past year cannabis use and past year cannabis use disorder among pregnant and postpartum women, right? And maybe some of you are familiar with the association between substance use and mental health disorders, and saying, "Oh, it's no new news there. Why would you do such a study? This has a lot of face validity." Well, most studies, particularly when it comes to prenatal cannabis use or cannabis use among pregnant and non-pregnant reproductive age women, they mainly focus on depression and anxiety. And they pull all mood disorders together and all anxiety disorders together. So essentially, you're looking at the association between a general class of anxiety disorders that's aggregate and an aggregate mood disorder or depression variable and substance use. That's typically been the focus. What I've been able to do here was add some specificity, right? So sure, I examined the relationship between any, if you see my cursor, any past year mood disorder and cannabis use and cannabis use disorder, any past year anxiety disorder, any lifetime personality disorder, just to see if my results are at the national level are consistent with what I've been seeing in smaller studies using clinical samples and less representative data. And sure, this study confirms other findings. Any past year mood disorder, once we aggregate the conditions, any past year anxiety disorder, any lifetime personality disorder, certainly all significantly associated with increases in cannabis use and past year cannabis use disorder. What we did not see, what past research did not examine, was the specificity, and we'll get into that. So moving back to mood disorders, all mood disorders, at least examined in this study, were associated essentially with past year cannabis use and past year CUD, cannabis use disorder, except for bipolar disorder. Bipolar disorder was associated with significant increases in cannabis use amongst pregnant and postpartum women, but it was not associated with the more severe cannabis use disorder. Similarly, for lifetime personality disorders and PTSD, each lifetime personality disorder and post-traumatic stress disorder were associated with both past year cannabis use and past year CUD at the national level. We see variation here when we get to anxiety disorders. And this is what I found most interesting about this study is this variation. So we see, again, any anxiety disorder, when you aggregate all disorders into one variable, sure, that's associated with both past year cannabis use and past year CUD significantly. However, when you start to look at specific anxiety disorders, and this is where you can potentially begin to tailor treatment, you see that some anxiety disorders are significantly associated with increases in past year cannabis use, particularly social anxiety disorder and panic disorders are associated with two times or more higher odds of past year cannabis use amongst pregnant and postpartum women compared to those who did not have that disorder, right? However, this is not consistent as we move to past year CUD. The same anxiety disorders that are associated with cannabis use are not necessarily associated with cannabis use disorder, right? So we have to begin to think about, as we progress from cannabis use to more severe cannabis use, such as cannabis use disorder, what are the correlates that are associated with that progression, and how do we intervene, right? So, and we need more research to examine that. This study couldn't tease that out. But I look at, when I look here, it's something to just at least to begin to think about. And if we move back just for a second, because past year, in terms of anxiety disorders, other than any anxiety disorder, cannabis, people who use cannabis and those who had cannabis use disorder, they did not share anxiety disorders in common, right? So specific phobia, for example, was associated with cannabis use disorder, but not associated with cannabis use. Social anxiety disorder was associated with cannabis use, but not cannabis use disorder. Panic disorder was associated with cannabis use, not cannabis use disorder, right? So there's variation there. If we move back for 1 second and to consider either the mood disorders or the lifetime personality disorders, but let's just stick here with the mood disorders. I wonder, in terms of future research, this is what future research should examine in this area. As the progression, as people progress from cannabis use to cannabis use disorder, are they more likely to progress if they have a mental health condition or a mental health disorder that's a common correlate of both cannabis use and cannabis use disorder in terms of pregnant and postpartum women? So, for example, pregnant and postpartum women with major depressive disorder and persistent depressive disorder, for example, are they more likely to progress from cannabis use from cannabis use to cannabis use disorder, since persistent and major depressive disorders are a common correlate of cannabis use and cannabis use disorder amongst this population? Whereas when we're examining bipolar disorder, that's not common correlate, right? Bipolar disorder was only associated with cannabis use, not cannabis use disorder. And likewise, with anxiety disorders, there's no common correlate. So I don't know if people with panic disorder, for example, pregnant and postpartum people with panic disorder, are they likely to transition to CUD, right? Panic disorder is not associated, at least at the national level, with cannabis use disorder. Something to think about. But given that cannabis use is legal in this country, given the decreases in perceived risk, I wanted to examine potentially whether or not pregnant and postpartum women were using cannabis to self-medicate mental health disorders. And it's possible that they are. This is a cross-sectional study, so certainly we need longitudinal research to confirm such a hypothesis, but this is the first step in thinking about that. So that's what I examine. And this is not any time postpartum, this is up to 1 year postpartum. So when I look at this population, there's this critical period between pregnancy and up to 1 year postpartum where women in that category might be using cannabis to self-medicate mental health disorders, particularly during that time. So why does all of this matter, and why does it matter now, right? Cannabis use is associated with poor maternal and child health outcomes. So because of that, we need to understand trends in prenatal cannabis use or cannabis use during and around the time of pregnancy, for that matter. And we also need to understand correlates of cannabis use during and around the time of pregnancy if we want to prevent cannabis use and associated poor maternal and child health outcomes. So in human and animal studies, what we see is that cannabis use is associated, prenatal cannabis use particularly, is associated with low birth weight in human and mice, and with neurodevelopmental deficits in human and mice, right? In human studies, we see that there's an association between cannabis use and maternal anemia. Now, the question is still out, well, how harmful is it? You know, what are studies controlling for? We definitely need more research. A lot of research in this area is cross-sectional, so we definitely need longitudinal, well-controlled studies to confirm some of these findings. Also, we need studies that control for tobacco use, right? A lot of the maternal and child health outcomes that are associated with cannabis use, in terms of prenatal cannabis use, are also associated with prenatal tobacco use, right? And if we're not controlling for prenatal tobacco use in the studies that examine prenatal cannabis use, the question remains, like, is it prenatal cannabis use that's associated with these poor maternal and child health outcomes, or if it's really prenatal tobacco use? We just need more research to confirm that. But the state of science that we do have as of today says, yes, there are associations, and poor associations, in terms of maternal and child health outcomes, in terms of cannabis use, prenatal cannabis use. And that's why the ACOG and the American Academy of Pediatrics recommend that pregnant people considering pregnancy, and women who are postpartum abstain from cannabis use, right? So those recommendations make sense in terms of the current state of science. It is a tall order to fill, at least from my perspective. You can tell me if it's easy for you, right? To make and promote these recommendations and promote maternal and child health, given the current social political landscape, right? Where cannabis use is legal essentially across the country. And I'm not advocating that it shouldn't be legal. It's neither here nor there. That's not the point of the talk. The point of the talk is that cannabis is contraindicated during and around the time of pregnancy, for that matter. And we as scientists and practitioners have to find a way to protect maternal and child health, prevent unintended consequences for pregnant people in the context of cannabis legalization, right? I'm not talking about other populations. If you're going to smoke recreational cannabis use, that's your business, if there's no contraindication for that. But pregnant people should not, right? So let's look at where we are as of recently. So 38 states, 3 territories in DC have legalized medical cannabis, including New Jersey. 24 states, 2 territories in DC have legalized recreational cannabis use. So here's a map of that. That's essentially the whole country. And I'm sure, well, not almost the whole country. And I'm sure in 5 or 10 years from now, these numbers are going to change. It's going to be, maybe 48 and 32 here. Point is, cannabis is being rapidly legalized for medical and or recreational purposes across states. And when we look at similar laws, if we're sticking with policy, we have cannabis use laws that are progressive, right? Cannabis is legal, but we have maternal and child health laws that are antiquated, right? While cannabis use is legal in most states, we are still criminalizing prenatal substance use. We're mandatory reporters. You are mandatory reporters. I'm a mandated reporter. I'm no longer a nurse, but I am a social worker, right? So 25 states in DC have mandatory reporting laws regarding prenatal substance use. And every time I give a talk similar to this, it could be about a different drug, not necessarily cannabis use. People say, oh, well, we don't report cannabis. It's random on what you do report. The law doesn't say not to report cannabis and only to report cocaine and crack. It doesn't say that. So the policy is, one, antiquated, and the way it's implemented varies from practitioner to practitioner. And that's problematic in and of itself, right? So we're still reporting prenatal substance use for the most part instead of treating it. There's no science that says when we report pregnant people to Child Protective Services for substance use, including cannabis use, that it improves maternal and child health. So my question here is, why are we doing it? And as mandated reporters, why are we not saying more about this? We're just, going with the status quo. Call it DCP&P if, the mother tests positive for substances, but not thinking about, are we really harming our patients because of this policy? We're put in a situation where we're faced with protecting our license and protecting our clients and our patients. Anyway, ACOG recommends that you don't do this, that you holistically treat the patient, that you work with policy makers and legislators to actually repeal these laws. But nevertheless, 25 states clearly in DC think differently. 24 states in DC consider prenatal substance use child abuse, and 3 states consider it grounds for civil commitment. 19 states have created or funded drug treatment programs focused specifically on prenatal substance use. So I'd like to show this map and show the policies here because they're discordant. Progressive cannabis use laws, antiquated maternal and child health laws, and within this social political landscape, we have to protect pregnant people and their children. It's hard to do. And it brings me back to the model. I said we were going to get back to it. And now I really want you to think about where are we in terms, literally, in terms of prenatal cannabis use and cannabis use legalization. Let's break this model in half in terms of the left side and the right side. This is where we often are. We live as, and myself included, when I was a practitioner, no one enforced, unless I, took a extra class or something like that. But no one enforced or even suggested that I advocate for changes in policies. This is what happens in practice. If mom tests positive, right, for cannabis or another substance use, we have to circumvent or help prevent maternal and child health, poor maternal and child health outcomes, as we should. But this is the part that's odd to me, right? If they test positive, we have to report them. And these negative social consequences contradict maternal and child health. So when we often face prenatal cannabis use in the clinic, we're doing, on one hand, we're promoting maternal and child health. On the other hand, mandatory reporting laws mandate that we report pregnant people to Child Protective Services, and that contradicts maternal and child health. Why are we in this situation, right? We have to do something about this. And the way that these mandatory reporting laws are implemented are often biased. But that's the truth of it. I want to challenge you to think about breaking this cycle and think about the left side of this model. How can we intervene here, right? I talked about risk perceptions. How are we going to, at the clinic level and beyond, intervene on risk perceptions of prenatal cannabis use? Again, when it's legal in New Jersey doesn't even have mandatory reporting laws, it has a voluntary reporting laws, and people are in family court every day. Someone's probably there right now because of prenatal cannabis use, because we're so used to the status quo, reporting people who use drugs, right? Because that's what the that's what the right-hand side of the model tells us to do. But we need to operate here. We need to operate here. What are the predictors of prenatal cannabis use? It's too late. Once we're here, it's too late. We're reacting. We need to act here, right? What are those upstream social determinants of health that's leading to prenatal cannabis use? So here's some action steps, right? I won't go through all of them, but I did put a couple of papers here. If you want, you can read them, where I lay out where I described plenty of action steps. That I called my senator, I called the legislators in New Jersey, and I called my legislators. I scheduled a meeting. I told them my ideas of what should happen in terms of protecting pregnant women in the context of cannabis use legalization. For example, there's no policy, it's not specific. It does not say, there's no warning labels, even on point of sale. It's not mandated that cannabis labeling says, hey, pregnant people should not use the drug. The actual state policy does not give any specific information in terms of how what population should not use cannabis use, other than youth, which is a good thing. So again, talk to your legislators and think about these other points, right? Certainly we need to have maternal and child health policy that is not antiquated, but that actually promotes maternal and child health. We need to think about how we're training our scientists and our physicians to treat and promote health equity in terms of prenatal substance use, including prenatal cannabis use. I already talked about some limitations in the research and the need for warning labels, and could borrow. We can borrow from other policies in terms of tobacco and particularly alcohol use. Stores or outlets that sell alcohol, liquor stores, for example, there are density regulations, right? So, or sometimes moratoriums. So the number of alcohol outlets, for example, in some jurisdictions are limited if they're around the school or if they're in certain areas. In some places, you can only have an alcohol outlet when it's in some type of shopping plex. It can't be in a residential area. We need to borrow from policies that exist in terms of other drugs, and so we can help prevent the unintended consequences of cannabis legalization for pregnant people. And these are things we do beyond clinical care. So when I think about training, I know we have to wrap up soon, and I promise you that we would develop some action steps. And this is the last thing I would say. So, I mentioned I opened this drug treatment program in honor of my late mother. And this was in Baltimore. I don't think I told you where it was at. So when I was a PhD student at Hopkins, I also had, prior training. I was a nurse. I was a licensed social worker and a couple of other things. I opened this treatment center, and residents from the Johns Hopkins School of Medicine, Internal Medicine, and Pediatric Urban Health Residency Program, they trained at the center. They completed their women's health and community health rotation with me, and they're not obstetricians, but they learned women's health. However, importantly, they learned how to address social determinants of health directly. They are outside. We have a whole center. You can, put on your white coat and go inside and see the patients, and they did. But they made house calls. It's one thing reading about social determinants of health in whatever textbook you're reading about, in whatever article, and it's a different thing when you're making a house call to a community member in the neighborhood that we serve, and you see that the community member doesn't have steps. How are you as the physician going to, you understand it differently there. Getting into this house to see this patient who can't seek care, who can't come to your office, and you have to figure out how to get up into the door with no steps. You might understand transportation barriers differently, and then you might do something about it. The clients was not, or the patients, the community members, they weren't interested at first in seeing these physicians, right? If they have the community, I'm not from Baltimore, so the community there, they have a whole different relationship with Johns Hopkins, and it just sometimes it's they have good perspectives, and many times they don't. So it was a point against these physicians that they were Hopkins residents coming to do God knows what from the community to the community members. That's what our community members told us. We took years to develop rapport with them, but in order for the doctors to do that, they had to meet the community members where they were. If I feed you, if I offer you food at the table because I know this is a food desert, you'll talk to me because you're going to come and get the food, and now I can engage you in care. And now you trust me, and now you know that I'm actually a physician here to help you and not harm you. But it's you interact with clients who are seeking care very differently than you do with those who aren't seeking care. So these physicians, they went out to actually seek the clients who needed care but could not seek them out. And this is one of the ways that I thought about training physicians and practitioners differently. So I want to spend, I want to leave this last 10 minutes for questions and answers, actually. But I want to orient you to these last 3 slides, right? And you could take a picture of them if you want, or I can have at least the last 3 sent to you. I made a template for you to take some action steps, right? This is what I wanted us to practice, but we only have a few minutes. To think about how you can improve clinical education. Go through as many of these as you can and make a plan. Many of you are clinical educators, are students at the moment, are residents. You know what's going right and you know what needs to change. List that there. Think about your strengths in terms of resources you have at the organizational level. What don't you have? And how can you drive change, right? This is what I wanted us to practice today, but time is running out. And do that for 6 or 60 things that need to change in terms of clinical practice, specifically as it's related to, in the context of this talk, preventing prenatal cannabis use and preventing unintended consequences of cannabis use legalization for pregnant people. Do the same thing for clinical practice, right? What are we doing when we see our patients, and can we do it better in terms of those patients who have substance use disorders or otherwise misusing substances or using substances during periods like pregnancy or postpartum when it's contraindicated. And again, the same thing for policy. What are your talking points for your legislators? Hold them accountable. They want your vote, so you need them to do something, and they should, right? What are your talking points? What do you want to talk with them about? And what are your specific asks? And I've done this. It didn't take a lot of time. I emailed Senator Booker's office one day. They emailed me back in maybe 15 minutes. And I presented a talk similar to this. I had some talking points and some acts. And it's a real thing that can happen in real time. And this is how you can at least begin across these 3 slides to think about what you can do, not only in the clinic, right? But in addition to clinical practice, in terms of preventing potential unintended consequences of cannabis legalization for pregnant people. I'm going to stop sharing now because now we have a few minutes for questions and answers, and I'm happy to take questions.
Thank you, Dr. Brown. Thank you for that excellent talk.
You're welcome. Very happy to be here.
Are there any questions? I see that Dr. DiCenzo has a question.
Okay, please ask it.
Okay, hi, I'm Natalie. I'm one of the residents.
Yes.
Thank you so much for this talk. I think it is super relevant to our patient population and to OB/GYN in general, like whether or not we need to act as agents of the state, particularly related to abortion as well. But I guess aside from that, I just was wondering if you could comment on some of the disparities in terms of how systemic racism interplays with all of this. I think on an individual level, us as clinicians are very racist in the ways in which we maybe selectively pick who we want to do a UDS on or who we think is a more concerning patient with a substance use disorder. So maybe could you discuss on a macro level how you see that playing out, especially through like a social work lens?
Yes, I can, and that is a good question. And I want to, so I'm going to share just one more time, because I actually talk about that in these two papers, right? Can you see my, I'm getting some messages here pop up. So I wrote about, partly about the role of racism in terms of mandatory reporting laws across these two papers. So I published first in the addiction, talking about, particularly focused on pregnant people. JAMA Network Open invited my colleagues and I to kind of expand this discussion to talk about pregnancy, preconception, and lactation. So, I encourage you, if you want to read those articles. But when it comes to mandatory reporting laws, these laws that say, hey, antiquated laws that say, report pregnancy, drug test is positive during pregnancy, report these women and pregnant people to the authorities, report them to Child Protective Services, which could lead to child separation, right? And there's no evidence that this even works. ACOG recommends that you don't do this, right? The way, and I tried to touch on this briefly earlier, the way that it plays out in practice is that practitioners, those of us who actively see patients and clients, they choose what they report. Like, they might not report cannabis, but they might report crack. Some people are reporting everything, right? And this is still in New Jersey, where New Jersey does not have mandatory reporting laws in terms of prenatal substance use. So why are we doing it? So not only that, you pick and choose what you're reporting in terms of prenatal substance use. There's no one to hold you accountable to that. And there's no regulation to even guide you in how to do that. But even when prenatal substance use doesn't differ, according to the science, and again, I've talked about this in my papers, even when prenatal substance use doesn't differ by race and ethnicity, Black and brown women are reported more often than non-Hispanic white women. So that is certainly where racism, structural racism, and just pure individual bias come into play. And we have to do something about that. And maybe it's going to be better training in terms of clinical education, but it has to certainly be regulating these policies, right? Our organizational policies and our macro level policies are going to dictate what we do. And it is very difficult to fight against the status quo. And it's very difficult to combat bias and racism because, some people are outwardly racist. Okay. But most people, I would like to think, most people in helping professions want to help you. It may be hard for them to determine if they're being biased or not. But according to the science, even when there's no difference in prenatal substance use by race and ethnicity, Black and brown women are more often reported. So I hope that answered your question, at least.
Yes, thank you so much.
You're welcome. Are there any other questions?
All right, well, no more questions, and we're just about out of time anyway. Dr. Brown, thank you so much.
Very welcome. Thank you for having me. Have a good day, everyone.
Thank you so much. So we'll end it here, and I wish everyone a safe and successful day.